All right. So today we are going to be talking about hospice and advanced care planning. And with us today, we also have special guest Leanna Clegg. Sorry, I'm probably pronouncing it wrong. With Bristol Hospice. Um, and we also have Nellie Camarena, one of our nurses out of the Chico office. And again, Katie with the Reading office. So in a moment, I will be turning the presentation over to Leanna. Her presentation will be followed by discussion of advanced care planning, advanced directives and posts, special considerations for our clients, and the Alice Carroll Foundation, and how they can support our clients. I'll also talk a little bit about hospice, including the hospice waiver for our community care licensed facilities and day programs, as well as palliative care. There will be time to ask questions and make comments at the end of the presentation, but if you have any questions throughout the presentation, please feel free to unmute and ask. You are welcome to use the chat box as well. I might miss your message during the presentation, but if that happens, hopefully we'll get that at the end of the day. And with that, I will hand this over to Leanna, and thank you for joining us today. Did you need screen sharing abilities?
No, okay. I'm just going to kind of go through a few things. I have to first apologize for the horrible lighting in my office and the reflective glasses, number 2. But truly, it's an honor to be. Can you guys hear?
Yes, we can hear you.
Okay, good. It was cutting in and out a little bit. It's truly just an honor to be involved today. I know so many of you are such difference makers in our community, and I'm just grateful to be able to share a little bit of hopefully insightful information for you all. My name is Leanna Clegg, and I am a proud liaison for Bristol Hospice. I'm going to start off with a question, and I want you guys, if you don't mind, just kind of answer out loud. When I say the word hospice, what is the first thing that comes to mind? I'm not hearing anybody. Is anybody saying anything?
It looks like we have some mentions in the chat box. Death, comfort care.
Got it. Okay, perfect. A lot of times what I get is death. That's what I most commonly get. And it's like, well, that's why I'm here. I want to kind of give everybody a different perspective on what hospice care is nowadays. We definitely do provide end-of-life comfort care to those patients who are in need of it, but we are able to bring patients on a lot sooner and earlier in their disease process than we used to be able to, as long as they made the qualifications. I'm going to read a brief definition of what hospice care is, because I think it's so many different levels. It says hospice care is an expert healthcare team for people nearing the end of life that have stopped curative treatments. Hospice offers physical, emotional, social, and spiritual support for patients and their families. The focus is on quality of daily life. And there are a few reasons why I wanted to talk to you about hospice care today. The first is there's actually been a change of culture in the hospice world, and I want to share those changes with you. I want to give everybody an accurate snapshot of what the hospice benefit covers, because oftentimes I find that it's kind of a more robust or bigger benefit than people realize. And the biggest reason I'm here and work for a hospice agency is my own personal why. I had a sister who died at the age of 34 years old, and I'm sure that sounds absolutely crazy to say she died a beautiful death, but she had a brain tumor and there was no cure for her, and she was very anxious, very agitated, and in a lot of unmanaged pain. It was awful. And once we brought the hospice team on, they completely made her comfortable, anxiety-free, and she was able to just relax a little bit and come like grasp the fact that she was at end of life and she passed a very peaceful death. And I'm grateful for that. It changed the trajectory of my life literally. And I'm here today. Most people that work in hospice have a why. And like I said, my sister changed my life. So changes in the hospice world, what am I even talking about? So it used to be that people would always wait until a family member was almost dying. And same thing with providers. They would wait until a patient was almost ready to pass away before they would call on hospice. But nowadays, we are able to bring patients onto service much earlier than we used to be, as long as they do qualify for care. There are a lot of misconceptions that are being dispelled about hospice care. You know, you hear that it hastens death, that you can only be on hospice for a limited time. If you go on, you can never revoke off, which is none of these things are true. Or hospice is surrendering or giving up. And it's really not the case. Research actually shows that if there are two different patients with the same disease on hospice, one not on hospice, that patient that is on hospice will likely live 30 to 60 days longer, which is pretty amazing if you think about that. So who is the hospice appropriate patient? If I'm telling you it's kind of changed a little bit, who are we talking about? We're still talking about a patient who has no cure for their illness and they've stopped seeking curative measures. We're talking about a patient who just has a non-curative disease and they don't want to pursue aggressive treatment. Again, non-curative patients, but they are exhausted from going back and forth to the hospital and back and forth to doctors' offices with no different outcome on the other side of it. And any patient who is dependent on 3 of their 6 daily living activities will usually qualify for hospice. And I think most of you know those, but we're talking bathing, dressing, eating, toileting, transferring. I know I'm missing one. Sorry. But, you know, we are able to bring on a lot of Alzheimer's dementia patients a little bit earlier than we used to, because they are dependent on 3 of those 6 ADLs. And it's a tremendous support and help to their family and caregivers. The hospice benefit is quite robust and is covered 100% by Medicare, Medi-Cal partnership, the VA, and all private insurances are billed. The average person who is on hospice care in the United States is on hospice care for 3 weeks. So it's interesting. My experience here at Bristol is we have a lot of families who, after their loved one passes, will say, I wish we would have known about this sooner, because we can go in there with the bath aides, the nursing team. I'm going to talk to you a little bit about everything hospice provides in a second, so I don't want to be repetitive, but it's pretty interesting when you have families saying that. So every hospice agency across the board has to provide certain things. Those things are a clinical team, which is comprised of your medical director, nurses, and bath aides. Everybody has to provide a social worker, a chaplain, a bereavement coordinator. We all offer volunteers. And then any patient who comes onto service with any hospice agency is given a comfort pack of medications. Now, this is another one of those misconceptions. You know, you hear, oh my gosh, you know, hospice overdoses people in morphine. It's not true. We microdose them and we just manage whatever their symptoms are that need to be managed. But some people, believe it or not, never end up needing those comfort pack medications. There's more in there than just pain. There's also like anti-anxiety medications, et cetera, et cetera. The hospice benefit also includes all durable medical equipment. So hospital bed, bedside commode, wheelchair, shower chair, oxygen, anything that patient might need that's under the durable medical equipment category. Hospice also supplies all medical supplies like briefs, wipes, gloves, mouth swabs, Chuck's pads, anything like that. And then all medications for that patient are provided in the home, which obviously just makes it so much easier on the caregivers who are trying to not only be caregivers, but also run around and make sure they have everything they need. So Um, our nursing staff, or every agency has a nursing staff that's available around the clock. So hospice, when you come onto hospice, the agency is your new 911, and the family calls you when anything changes. And every agency provides a lot of caregiver and family training and support. That's part of our job that we do. So Bristol Hospice, what makes us unique? I think our accessibility is unparalleled. We have an hour response time for referral or consultation requests, and we do them all in person unless the family says, nope, this is what we need. Let's just handle it over the phone. Our liaisons, which is what I am, we're available anytime for families, patients, or partners to text or call us. There are a lot of times when we go to a consultation and you're giving the patients and their families so much information that when you leave, they have questions. And so we make ourselves available. They can text, call, whatever they need, weekends, evenings, we're here for them. And we never will turn down any consultation if we're asked to provide one. We also have superior communication with our referral sources. Another thing that I think is pretty unique to Bristol Hospice is we take a palliative approach to hospice care. I have to be careful with that. We don't provide palliative care. I don't know that anybody in town does, but we take a palliative approach. And what I mean by that is that we allow advanced respiratory support for patients who need it. That would include like a CPAP, a BiPAP, a Trilogy breathing machine. So patients who have respiratory distress, a lot of agencies will remove those pieces of equipment and just give oxygen. And we feel that those patients can't really have a peaceful passing without the aid of those breathing machines. We also accept higher acuity patients. And I think we're the only agency, I'm not positive, in town that accepts ALS patients, a patient with a feeding tube. And again, we do that because we believe they deserve to die with compassion, love and grace like everybody else. Our medical director's local. It's Dr. Timothy Peters. He's a very well-respected physician in this town and practiced rheumatology for well over 30 years. We also have a nurse practitioner. All care plans that we create for patients are customizable. And physicians in our community, if they would like, when their patient comes to our service, if they would like to follow their own patient, they are allowed to. We do offer that to our physicians. Bristol has some specialty programs that are unique to us. I think the most popular is called Bright Moments. I'm sorry, it's kind of weird to show it to you on the screen if anybody would like to know more about it, but it was created through research, and it was created for Alzheimer's dementia patients. And it is a non-pharmacological, it's a kit of non-pharmacological things that would soothe or help a patient calm down if they start sundowning or just having anxiety or wandering. There's a weighted blanket, a bear that goes in the microwave, all different things in there, but it's a pretty cool thing. And we get great feedback from families. Anyway, I'm hoping that all of this information, I know it's a lot of talking, I apologize, but gives you a change of perspective in hospice care. And just know that we are a resource in our community for you should you ever have any questions for your family members, patients, or clients. Death is hard, but what's harder is watching a loved one struggle or suffer as their end of life as their life comes to an end. I know this because I lived it. When my father passed away, he was not on hospice. He was in a local facility, and they assured us that they did end of life comfort care. And his passing was the most traumatic, awful death I've ever experienced. And it's just something that my mom and I will never be able to forget. But I guess it's one more reason why I'm so passionate about what we do and this care that we give to the patients that come onto our service and families. Obviously, we can't change death, but what we can do is work together to provide comfort and peace for our loved ones. We can meet them where they are. love, honor, and support them as we walk beside them until they do reach their end of time on this earth. Bristol Hospice would like to encourage you to have those tough conversations with the loved ones in your life to ensure that their wishes are honored and respected. So please feel free to reach out with any questions at any time. I don't know if anybody has any questions.
Hi, this is Nellie. Thank you so much. That's really great information. I had a question as far as like the cities or counties that you serve. Just because with the regional center, we have a vast catchment area. I know you're based out of like Reading, but I was wondering like what other surrounding cities you serve.
Absolutely. So we're currently serving Shasta County. We have just expanded down into Tehama County, kind of going to Corning, Red Bluff Corning area. We are up in Shingletown. I think right now we have about 5 patients in Shingletown. And the most exciting news that I have to share with you about this is we will very soon be opening in Weaverville, which probably most of you know is an unserved population. I'm really excited about that. We have taken Weaverville cases on a case-to-case basis if we could manage it. But we have recently brought on some more nurses and, caregiver and healthcare or bath aides. And so I would imagine within the next several months, we will be expanding up into Weaverville.
That is great. Thank you. That's super exciting.
Well, thank you very much for joining us today, Leanna. I really appreciate it. And if you have like any contact information for any of our providers here, if you could enter it into the chat box, that would be very helpful, just in case they do have any questions later on. All right, so we'll move on here and begin to talk about advanced care planning. So advanced care planning is essential for ensuring that our clients receive the level of care that they desire in the event that they are incapacitated and unable to make their own medical decisions. They can do this through documents such as advanced directives. In the images here, you can see the white form is the standard advanced health care directive you can find in California. It's often handed out like at your primary doctor's visits. Or the image there in green is a workbook called Thinking Ahead. It was developed by the Coalition for Compassionate Care of California for individuals with developmental disabilities. It is specifically designed to be easy to understand and fill out, whereas the white form, that standard advanced directive, is a very clinical document and it can be difficult for some individuals to navigate. And a little later, I'll also talk about the Alice Carroll Foundation and how they help develop plans for our clients. So what is an advanced directive? It's a client-specific and initiated document that details the client's specific wishes, including what medical treatments they do and don't want, the designation of a healthcare proxy in the event the client is unable to make their medical decisions due to illness or injury. This document can be copied and distributed to the client's medical providers and support personnel. The advanced directive can be revoked at any time by either completing a new directive, which would supersede the old, physically destroying the old directive, as well as by providing a signed and dated or an oral statement to anyone with the old directive with the intent to revoke. So say the client has an advanced directive, they've given it to, say in our case, to the home that they're living in, so that way it's available in the event that they go to the hospital, but their primary doctor also has a copy of it. They could have a family member who has a copy of it. If they decide that they want to change their advanced directive, they can either supply a new document to whoever has that document and it'll supersede it, or they can send a letter or call whoever has that document say, hey, I'm changing my advance directive. Please get rid of the old one. So that would be the advance directive. A POST is a physician order for life-sustaining treatment. It is it's a portable medical order signed by a physician, and it provides clear instructions of the patient's preferences in regards to CPR, intubation, and artificial nutrition. The form in the state of California is on a bright pink cardstock document so that it is easy to locate in times of emergency. A client can designate whether or not they want medical staff to attempt resuscitation with CPR, or designate themselves as wanting a DNR or do not resuscitate order. If a client chooses to elect for CPR intervention, they are required to consent to full medical treatment, including IV medications, intubation, mechanical ventilation, etc. They can, however, specify a trial period of full treatment before life-sustaining measures are discontinued. If the client elects for a DNR order, they can opt for selective treatments such as DNI or do not intubate, in which case, if they required respiratory support, they could be put on something like a BiPAP, a non-invasive respiratory supports. They can also specify that they would rather providers focus on comfort-based treatments, such as supplying oxygen. And this is if they selected DNR. They can, they can also specify whether they would rather providers focus on comfort-based treatments, such as supplying oxygen, providing medication to alleviate pain and suffering, suctioning, etc. If the client in your facility were to become unresponsive, on their POST, they can specify whether or not they want to be transferred to the hospital only if their comfort needs cannot be addressed in their current location. And there is a line on the form where additional orders can be handwritten. In regards to artificial nutrition, the client can specify whether or not they'd prefer long-term artificial nutrition, including feeding tubes. This could be IV nutrition, nasogastric tubes, or gastric tubes. The client can also specify whether or not they would prefer a trial period of artificial nutrition. They can say, I'm okay with getting food through an NG tube, for, a couple weeks, but if I'm not showing any signs of improvement, I definitely don't want a G tube. I want nutrition to be pulled at that point.
Katie, I'm wondering if you have a PowerPoint to share.
Of the POST?
Yeah, or if the copy of the POST is on the PowerPoint. The slide share, I'm not able to see it. I don't know if anyone else is.
Does it say advanced care planning and there's the pink form?
Okay.
It's so small. I'm sorry. Is that slide showing? Or is it not changing for you guys?
I can't see it, but I don't know. I'm also on the iPad, so I don't know if other people can see the PowerPoint.
I can see it. Okay.
Okay, perfect.
All right. That makes me feel, I was a little bit worried about that. Sorry. So, and then there's also a place for the client to say that they don't want any artificial nutrition. And the last section where the client can make choices about their medical care is, let's see, they can indicate whether or not they already have an advance directive. And if so, when was it written? Who has a copy of it? So they know exactly where the advance directive is. They can also indicate that, yes, I have an advance directive, but I don't know where I have it. Or they can say, no, I don't have an advance directive. It's nice having that on there because when a physician's looking at that POST in the event that it's an emergency and we're trying to decide what the client's wants are, we can just quickly see they have an advance directive, we can locate it, or they don't have an advance directive, we don't need to bother looking for it. And then there will be a place for the physician, the nurse practitioner, the physician's assist, or the PA to sign the order, and then also a place for the client to sign agreeing to the order. On the reverse of the form is a HIPAA disclosure that the client or their representative will need to sign in order to permit the disclosure of the POST document to other healthcare providers as necessary. So this were to be if your client has a pulse, it's in their binder, they're going to the hospital. You send a copy of the pulse with them only if that HIPAA portion on the back is filled out, because that's the client giving permission for that information to be shared with other providers. And this should be filled out every single time. There are also directions for the healthcare provider on the back of the form, but hopefully they're already aware of what their obligation is to honor the client's wishes on the pulse. And the pulse does not replace an advance directive. Ideally, they'd be compared to each other, so it's more support saying exactly what the client wants. If there are discrepancies between the two documents, those need to be resolved. Preferably, this would happen prior to an emergent situation. So client considerations. There are many things to consider for our clients in regards to advanced care planning. One of the first is that as our clients age, they may experience declines in their cognitive faculties. As their providers, their staff, you are generally the first persons to notice if there are any changes in their mentation or function. For this reason, it is really important to have your clients assessed by their primary care providers, and let their primary care providers know that there are changes in mentation. We are concerned that there is a decline in cognitive function. This may result in increased monitoring by the provider to say, okay, we'll see what's going on. It could also result in a possible diagnosis of dementia or referral to neurology to assess for specific disease processes related to cognitive decline. We could also end up getting new medications that would help slow memory degradation and preserve the client's functionality for as long as possible. If your client receives a dementia diagnosis, it will be imperative that a discussion is had with the client about making end-of-life decisions, with an emphasis that they're not actively dying. I find that sometimes when we initiate a conversation with clients about end-of-life choices, there is kind of like a feeling that I'm dying. And that's not the case. We just want to make sure that, when the time eventually comes, everybody is on board with what your wants are at the end of your life. Unless, of course, your client is actively dying, that's a different sort of discussion to be had. So let me, sorry, I got lost here a little bit. If your client has already declined to the point that they're not able to make these decisions, it will be important to determine who can assist in making any medical decisions for them. And I'll talk about this a little bit later on. In regards to healthcare, many of our clients have medical complications that are directly, indirectly, or unrelated to their regional center eligible diagnosis or diagnoses. These medical complications can occur in greater frequency and or earlier than the general population. As such, decisions about end-of-life care may need to be made much earlier in a person's life than an individual without a developmental disability diagnosis. And if you've worked with our clients for any length of time, you are probably already familiar with the viewpoints of many healthcare providers that medical intervention is not appropriate due to quality of life. And I use air quotes when I say that because quite frequently I will hear from a provider, we think that it's inappropriate to put in a G-tube because their quality of life is already so poor. But something to remember and to remind our healthcare providers is that this is our client's quality of life. They are happy. They have a full life at home. And even though this isn't what you would choose for yourself, they do deserve medical care and medical treatment. And so, yeah, this can be pretty frustrating for us because we know what their quality of life looks like. We know when they're happy. We know when they're not feeling well. So it's really important for us to be able to advocate for our clients while they're in the hospital. And one of the things that we do recommend is having like the health passport that goes with the client to the hospital. And ideally, the hospital would read these documents and understand our clients and know what our clients' wants are. Unfortunately, the reality is that those documents often don't make it out of the ER. They might not even have ever been read while they're in the ER. So it would be ideal to have someone who knows the client who can be with them in the ER when the physician rounds, explaining to the staff at the hospital who our client is, what their capabilities are, what their level of functionality is at when they're living their best life. So that way we can make, or the physicians are more familiar with the client, they can make more informed decisions about what a plan of care is. Sometimes even though providers may be quick to make a hospice or end of life decision recommend end of life measures for our clients in the hospital with more regularity than they would the general population. It is important to understand that in some cases, our clients are going to be in a position where comfort care, hospice care is a more appropriate option. And so it's really helpful to have the client have people who know them, who understand their wants and their needs to advocate for them at those times. So identifying a helper. The first things we want to do are, realize is the client able to identify people in their life that they would prefer help them make decisions in regards to their medical care? Do they have that capacity to do that? And if they do, make sure that it's documented somewhere where people know where to find it, who these people are. So in the event of emergency, we know how to reach them. Frequently, we have clients who end up in the hospital and a doctor is calling saying, hey, we need to do a procedure, but we don't know who the family members are. We don't know who can make decisions for them. And then it becomes a mad dash trying to find who can make these decisions for the client. It would be very helpful to have, I'm not sure how every home is formatted, but if each client has a specific binder, there should be a section based on, emergency contacts, like proxy decision makers, so that way we know who to reach out to that will respect the client's wishes. And then also, if the client isn't able to identify those people in their life, who comes and sees your client all the time. You know who their family members are. So keeping like a record of who those people are, and getting contact information. It's hard when you say, yeah, they have a brother who calls all the time, but we don't have their phone number. It's really hard to reach out to that person because sometimes we don't have that information on file either. So the more documentation we have of the individuals in our clients' lives who can help them make healthcare decisions when they're unable to is very helpful. So identifying a healthcare advocate is really important because unfortunately, our clients with developmental disability diagnoses frequently encounter physicians who are unwilling to accept their consent because they assume that because they have an intellectual disability, for example, they don't have the capacity to make those decisions for themselves. Even if they completely do, they can understand, maybe not in the same way that a physician understands what's going on with them, but they can understand, some of our clients can understand, when they're dying, when they, or maybe they just need someone to help them, or help explain it to them in a way that makes sense to them. So it really helps to have an advocate assigned for your client to help stand up for them, say, hey, this person knows exactly what you're saying to them. They're a person, they can consent for their own treatment. But then, of course, there are also cases where our clients don't have the capacity to make those decisions. And if that's the case and they don't have a conservator or a guardian in place, we want to make sure that they do have someone, it's generally a family member or a close friend who can help them make those decisions. And a little bit later, I will talk about the regional center's role in cases where we don't actually have someone designated. So the benefits of having a healthcare advocate is that this can decrease the length of hospitalization and minimize poor outcomes because there's someone standing there next to your client saying, hey, this is the treatment that they want. let's proceed with this. It's unfortunate sometimes we can prolong an individual's hospital stay because we don't know what they want, and so we have to do everything for them. Because if we don't have it written out what care they don't, they're going to get all the care. It can also help decrease stress at the times of a client's decline. To have an advocate, help them navigate whatever their health issue is. And this could be whether, it's just getting placement of a G-tube, or maybe they are at the end of their life and we're looking at a transition to comfort care and hospice. Having someone there who knows who they are and knows what they want and helps them stand up for themselves would be great at relieving stress. And it also allows for our clients' wishes to be honored. So the Alice Carroll Foundation, it was created to assist with life planning for individuals with developmental disabilities. And unfortunately, when you Google Alice Carroll Foundation, it does not show up in the search results. So I've included their link or their website address here, which is luckily very easy to remember. And you can go take a look at what services they provide on their website. But it is alicecarrollfoundation.org. And they provide services helping clients create facilitated personal care plans, which help them, in our clients indicate what their care wants are, they create clear directions for staff to help care for them, and also provides for continuity of care in case of emergencies. They also help with personal support networks by helping create a support network centering around the client. And in regards to end of life and advanced care planning, they also can help the client make an advanced care plan, which is basically helping them make their preferences for care at end of life known to those around them. And also they work with also supported decision making, which is helping the client make decisions based off of communication with preferred family members, friends, or other supporters in their life. So referring to the Alice Carroll Foundation, we'll go through the client service coordinator. So if you have a client who you're thinking, this individual could really benefit from having an advanced care plan in place. We're concerned they've got a lot of medical issues going on, and we want to make sure that their wants are respected and adhered to if the time comes where we need to talk about end of life. In that case, you're going to reach out to the service coordinator, and I feel like that would be appropriate time for the service coordinator to discuss with the client if that's something that they want to do. If the client doesn't have the capacity to make that decision, and if they're conservative, we want to talk to the conservator about that. And then the service coordinator will get a release of information and then can make a referral to the Alice Carroll Foundation. So the referral would go through the Alice Carroll Foundation. And then I know we already just talked about hospice, and I know that people frequently confuse hospice care and palliative care. So hospice care is for individuals who have a terminal illness with a life expectancy of 6 months or less. The treatment is comfort focused with symptomatic treatment. If the client changes their mind and decides they want to seek curative measures, they can leave hospice services and then return if they qualify later on. And people graduate from hospice all the time. It's amazing that sometimes individuals go on hospice and they improve and their life expectancy does increase. And so they graduate because they're no longer at that 6-month life expectancy anymore. And eventually they will likely come back onto hospice, but it definitely provides a greater quality of life. In palliative care, the focus of treatment is improvement of quality of life regardless of prognosis. So this could be somebody who has a prognosis of, they're going to be, say they have cancer and the doctor says, we think you have about a year left to live. They're not eligible for hospice at that point, but they are eligible for palliative care, which will focus on their overall quality of life, And they also will can continue to receive therapeutic treatment during that phase. So in the case of somebody who has cancer, they can still receive chemotherapy, but we're also still focused on comfort treatments. So in order for a client to either be admitted to or retained in your facility, if you're under the community care licensing, you will need to have a hospice waiver. And per the California Health and Safety Code, I believe it's section 1569.3. But the hospice waiver is required and can be obtained through the California Department of Social Services to accept and retain clients who are terminally ill and receiving hospice services. In order to qualify for the waiver, the facility must be able to demonstrate that they can support the increased care needs of the client, which may be beyond the facility's current licensure. And why is this important? A lot of our clients have lived in the homes that they're living in for years. They're familiar with the staff. They're familiar with the peers in their home. And death can be scary. It often is for, I think, most people, it is, they can be filled with a lot of anxiety. It's a big change. And so anytime we can keep our clients in a familiar environment, it's going to increase their comfort. And really that's what we want for our clients when we're talking about end of life care. So anytime we can get a client back home on a hospice waiver, that is definitely the preference. There are options, if the client's needs are too high for home, even with additional supports, there are, ways to get a client hospice service or hospice care outside of your facility. But ideally, we would like them to be able to stay in their home when they pass. And as I'd mentioned earlier about the regional center and consent for medical treatment, there are occasions where the client cannot consent for treatment. We don't have any identifiable family members who can consent for treatment. The client doesn't have any close friends who consent for treatment. And in that case, the director of the regional center or their designee can consent for that treatment. The thing to be aware of, though, is that the regional center cannot consent for the withdrawal of care. So we can only consent for treatment. Because of that, it is incredibly difficult, if not impossible, to get for the regional center to consent for hospice. There are very, very, very rare occasions where we can advocate that the hospice care is medical care. It is consenting to treatment. However, the regional center is not able to sign off on a DNR. That would have to be somebody else's jurisdiction. This is not something we would like to heavily rely on because it is limited what the regional center can do, and it often can result in delays in care. In a case where we have been successful in getting somebody placed on hospice, it took months and months of trying to get the client on hospice, and those were months that the client could have been at home and comfortable with their homemates, their family, rather than being in the hospital being poked and prodded every day for 3 months. So ideally, if we can have these decisions, either the client makes them before they need to be made, or they have a healthcare proxy who can help them make those decisions identified at that time, it would really alleviate a lot of unneeded suffering. Let's see. For some reason, my slide's not advancing. Okay, here we go. And this is a whole lot of legal jargon. So this is the California the Welfare and Institution Code 465 regarding the regional center's ability to give consent. And it is very, very detailed, but suffice it to say, in the event that there is no one else who can provide consent for our clients, we can provide consent for treatment. And that's for medical, dental, surgical treatment. So it's not just emergency medical procedures. If we have a client who needs dental care and there's no one else who can provide consent and their doctor is not willing to take their consent as being competent enough to give consent, then the regional center could provide consent in that instance. And so things to think about, it's good to look at the clients in your facilities and say, do these clients have an advance directive? Do they have a POLST on file? And if not, why not? Is this not something that we're concerned about? Do they have like a conservator who's going to make all those decisions for them? And if we don't have those things on file, those things that we can get on file. And then making sure, the regional center is aware that these documents exist. And if these documents do exist, do we know where to find them? And it's one thing to know your client has a POLST, but if you can't find it, it doesn't do you much good when your client has to go to the hospital. And something that I do want to mention is that you cannot rely on the hospital or the doctor to have a copy on hand of any of these documents. Every time your client goes in the hospital, you'll want to provide a copy of the POLST. You'll want to provide a copy of the advance directive, because when the client leaves the hospital, all of the records that came in with them that time get sent to archive, and it doesn't necessarily pull up on their chart the next time they come in. There might be reference to an advance directive, but the wants in the advance directive are not necessarily going to be on the client's portal or profile the next time they're admitted. So making sure that goes with them every single time they go to the hospital, so that way no one's scrambling for this information if it's necessary. And I apologize, we are a little bit short today, or I finished a little bit early, but does anyone have any questions or comments? Okay, I have put the email for the nurses here. If you do end up having any questions or comments, please feel free to reach out at any time. And that is my direct phone number if you have any questions specifically for me. And then again, if you haven't already, put your name and facility in the chat box so we can get you your CU certificate. And this how to get a POLST. So that would be through the doctors, like through either the primary doctor, or if it's a nurse practitioner or a PA, they would be the person to get the POLST through. All right. Well, if that's it, thank you very much for joining us today, and we look forward to seeing you next month.